think we can start, Bruna. Thanks, Bruna. We can start, I think. Welcome, everyone. I think we're going to start with the translation slide. Bruna? Great, thank you.
Welcome to your meeting with ICM. The interpretation. Welcome to your meeting with ICM. The interpretation button should appear at the bottom of your screen, next to the Share Screen button. By clicking on the interpretation button, you can choose the language you would like to hear. The interpretation button will then transform this meeting into the selected language. To change the language you would like to hear again, follow the previous procedure by clicking on that same button. By default, you will hear the selected language at 80% volume and the original audio at 20% volume. If you would like to mute or unmute the original audio, click on the corresponding option within the language button. Enjoy your meeting. Bienvenue à votre réunion avec l'ICM. Comme la réunion propose une interprétation simultanée en français, le bouton Interprétation devrait apparaître en bas de votre écran à côté du bouton Partager l'écran. En cliquant sur le bouton Interprétation, vous pouvez choisir la langue que vous souhaitez entendre. Le bouton Interprétation se transforme alors en la langue sélectionnée. Pour changer à nouveau la langue que vous souhaitez entendre, suivez la procédure précédente en cliquant sur le même bouton. Par défaut, vous entendrez la langue sélectionnée à 80% de volume et l'audio original à 20% de volume. Si vous souhaitez couper ou supprimer l'audio original, cliquez sur l'option correspondante dans le bouton de la langue. Bonne réunion. Bienvenido a su reunión de la ICM. Como la reunión ofrece interpretación simultánea en español, el botón Interpretación debería aparecer en la parte inferior de su pantalla, junto al botón Compartir pantalla. Haciendo clic en el botón Interpretación, puede elegir el idioma que desea escuchar. El botón Interpretación cambia entonces al idioma seleccionado. Para volver a cambiar el idioma que desea escuchar, siga el procedimiento anterior pulsando el mismo botón. Por defecto, oirás el idioma seleccionado a un 80% de volumen y el audio original a un 20%. Si quieres silenciar o desilenciar el audio original, haz clic en la opción correspondiente del botón de idioma. Disfruta de su reunión.
Thanks, Bruna. Good morning, good afternoon, and good evening to everyone. Welcome and thank you for joining us from all parts of the globe as we continue this series of AIME webinars where we explore the WHO Framework for Action, 7 Steps to Strengthen Quality Midwifery Education. Welcome back to those who we met 2 weeks ago and welcome to our newcomers. And I am sorry, but I am going to repeat myself a little bit for the newcomers. My name is Felicity Copeland. I'm a midwife based in Australia, working with UNFPA headquarters. And it's my very great pleasure to be part of AIME, the Alliance to Improve Midwifery Education, which is a partnership formed last year by UNFPA, together with WHO, ICM, UNICEF, as well as JPIGO, Momentum USAID, Lardell Global Health, Liverpool School of Tropical Medicine, and the Burnett Institute. So there's lots of us. And AIME is dedicated to supporting midwifery education and training globally and provides opportunities to come together to learn, to share, to network and learn about midwifery education globally. And please stay tuned for the AIME website, which is coming soon, and you'll see some of our outputs, which will include the sample midwifery curriculum, the direct entry and the post-nursing, as well as some standalone educational modules. So please watch out for that. AIME is grateful to Johnson & Johnson and to the Gates Foundation for their support. And we also acknowledge the vision and leadership of Geeta Lal in UNFPA headquarters and Sarah Buzzy. So I'm here today with my colleagues, Erin Ryan, the Midwifery Education Advisor from ICM, and Rosa Ann Seidler, the Program Analyst, Sexual Reproductive Health from UNFPA headquarters. And we are very ably supported by our colleague Bruna Bimbato, who is the Digital and Logistical Queen or Coordinator with ICM in Brazil. And a big special call out and thank you to our interpreters who are busy working hard translating for our Spanish, French and Arabic colleagues. So today's step 2 of the webinar series, gathering data and evidence. And we'll be hearing from 2 speakers who are going to share their considerable expertise about the significance of collecting and analysing midwifery data and the impact that this can have on a broad scale, not only across the education space. So we have you for 1 hour. Our aim is to make it interesting and stimulating, so we really want to hear from you. We know that we've all got webinar fatigue, so please use the chat box or the question and answer little platform on your screen to share your thoughts, your comments, to ask questions, to share, to network. This is your opportunity as we come together for 1 hour each 2 weeks. So I'm going to hand you over to my wonderful colleague, Erin, who is going to give you a brief overview of the 7 steps and then introduce you to a little poll where we hear from you. Thank you. Over to you, Erin.
Thank you, Felicity. I'm going to say pretty much exactly what I said last time, and I'm going to say it every time we meet. And hopefully by the end, we can unmute all of you. Today, it looks like 294 so far, and we can say this portion together. The WHO Framework for Action is helping improve quality midwifery education, which is urgently needed to improve the quality of care, end preventable maternal newborn mortality and stillbirths, and deliver the agenda of universal health care. After a global assessment and a long assessment, because the WHO does a very comprehensive assessment, they released this 7-step action plan to strengthen quality midwifery education. This framework for action identifies 3 strategic priorities for harnessing the power of midwives. 1, rethinking the education and certification of midwives. 2, strengthening midwifery leadership. And 3, stronger alignment of partners to improve quality education. The action plan can be used to develop or strengthen a national midwifery education plan. And this action plan recognizes the wide variety in midwifery education across countries. So we know that some countries are at the beginning of creating midwifery education and standards, and we know some are very advanced. And this plan is super flexible and adaptable, and anyone can use it to help strengthen their education. Now there's 7 steps, you see them on the screen. Let's just review those. There's strengthen leadership and policy, gather data and evidence, build public engagement and advocacy, prepare educational institutions and practice settings and clinical mentors, strengthen faculty standards and curricula, educate students, and then monitor, evaluate, and review and adjust. And then we start over. Next slide, Bruno. Today, we're going to be exploring step 2. And this is gather data and evidence. And I think people get a little intimidated and they think this is just for academics and it's a little bit hard. And I'm a midwife and what do I have to do with gathering data? But if we want our national midwifery education plan to be strong, we need to have data. We can't just say, well, I know that there's this many students and only this many students pass the test. I know it. We have to prove that we know it, and that's how we can make change. So our national education plan should be embedded in the national health plan, and it should be based on this current data and the evidence. And why do we do this? Because we need to know what's already in place, what is working, what do women, newborns, and families need, and what legislation exists. We want to be proposing things that strengthen and improve what's going on already, and we want proof of that. So the data and evidence collected in this action step is going to be updated on a continuous basis and used to inform all the other steps. So it's not hard to gather data. Let's gather some data about this group right here. We're going to do a little poll I did a little personal poll while you were all signing on and looked to see how many countries there were, to see how many countries came last time that came this time. And what I see is that India's got the greatest number here, and that we have people as far away as, for me, as far away, because I'm in the United States, as far away as Nepal. And for me, I think I'm the only American. Oh no, the interpreter is also here from the US. So there's 2 of us. So there's some data, and then I have some information. Let's look at the poll questions. I'll read the questions, and then we're going to pop up the poll, and everyone can answer, and you'll see the choices yes, no, or don't know. So 1, do you gather evidence or data in your current role as a midwife? 2, are you confident in gathering data and evidence to improve midwifery education? And 3, do you feel that your faculty or organization needs guidance in this step? Let's have that poll. Do you gather data or evidence in your current role as a midwife? Are you confident in gathering data and evidence to improve midwifery education? And do you feel that your faculty or organization needs guidance in this step? Go ahead and vote. And let's see what folks say. All right, I can't see how many of the poll questions have been answered. Bruna, can you take a peek? We've got 350 people. How many folks have answered? Can we see those results? All right, so do you gather data and evidence in your current role? Well, this is exciting. 78% of people said that they do, and 9% said they're not sure. So that's important information as well. Are you confident in gathering data and evidence to improve midwifery education? 72%, great. Are confident. And do you feel that your organization is in need of guidance? 84%. So looking at that, we see most people are gathering data, and they even think they know how to use it, but they also are still feeling like they're needing guidance. Well, let's see if we can offer a little guidance today as we go through our interviews with our panelists. I'm going to hand back to you, Felicity, for our first panelist.
Great. Thanks, Erin. And we love doing these polls because we get a real feel of what's going on out there and who's feeling confident and who's collecting data. So I'm really impressed that 78% are confident in that skill. So hopefully by the end of today, there'll be 100%. So it is my very great pleasure to introduce our first speaker, Andrea Nove. And Andrea is a researcher, a data analyst with 30 years experience, and her prime area of interest being sexual reproductive health. And what I love about Andrea's work is her skill in making complicated data really easy to understand and relevant. And many of you will know Andrea's work as she's the lead author of the State of the World's Midwifery Report. So it's wonderful that we have her, and she's the perfect person to start our discussion today. So welcome, Andrea.
Thank you, Felicity. It's great to be here.
Well, we are delighted to have you. So I think we should Andrea, just dive straight into the State of the World Midwifery Report. And I'm going to ask you to give a bit of an overview about it, the purpose of it, and why collecting this data is so important.
Okay, thank you. Well, that's a big question to start with. So the history of the State of the World's Midwifery, or the AIME report, as it's known for short. The 2021 report, which was the most recent, was the third in the series of global reports. The first was in 2011 and the second was in 2014. In between those dates, there have been a lot of regional and national midwifery workforce reports, but we're focusing today, I think, on the global reports. And the 2021 report was special in many ways, but one of the reasons I think it's particularly special is that it was the first one to include every country in the world. The focus in 2011 and 2014 was on low and middle income countries only. And now we have the high income countries in there as well. And I think that really helped to with a lot of advocacy messages, because we can see how different parts of the world compare with other parts of the world, and it's easier then to see where perhaps your own country or your own institution might be able to do better, or might be able to share its successes with others. So I would say the report is designed mainly as an advocacy tool. It takes a lot of data and tries to use that to stimulate policy dialogue at the global level, but also at the country level. And I think another reason why this is an important report and an unusual report is that it focuses entirely on the workforce. Most of the statistics and the data and the reports that we see look at service provision more generally. But we take the view here with SAUME that, you know, if you don't have a workforce that's adequate, you can't deliver all those services. So you really need to understand what's going on with the workforce in order to understand some of those other data and evidence that you see. It also acknowledges explicitly that midwives can't work in isolation, and they should not work in isolation. So it doesn't look solely at midwives, it also looks at the colleagues, the nurses, the community health workers, the doctors, the obstetrician gynecologists, to see where midwives fit within that wider team, and what the particular issues are. But having said that, the main focus, as the name suggests, is on midwives. They are presented as the backbone of the sexual, reproductive, maternal, newborn and adolescent health workforce. So in addition to these more general indicators about the wider workforce, we have a lot of indicators that are specifically about midwives, whether that's about their education or the regulatory processes or the environment in which they work.
Wow, that's a very comprehensive report. And I really like the way you refer to it as an advocacy tool, because you know, we need this data to, as you say, to stimulate policy discussions and dialogue, particularly around the, you know, the strengthening midwifery education space. So Andrew, you talked a little bit about indicators, and I'm hoping that you'll be able to do some screen share here and look at the country profiles, because this is a sort of a core component of the report, the country profiles. I'm wondering if you could talk us through some of those.
Yes, with pleasure. Can I just check that you can see my screen?
We can see the slide, the State of the World Midwifery Report, yes.
Yes, okay.
Great.
Yes, very happy to do that. So we thought it might be helpful today for those who perhaps are not familiar with how to find all of the SAUME resources, just to show you where they can be found on the UNFPA website. And particularly the country level data, which I think a lot of people are not aware that you can just get that and download it directly from the website. So if I can just walk you through that. So I've gone, if you can see, to the unfpa.org/SAUME page on the UNFPA website. And you can see here there's a reproduction of the front page of the report. And there's a real wealth of advocacy messages and information at the top of that screen. But if you scroll down, 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 all the way down to the bottom of this page, you get to a section with a world map. And this is where you can access the data and information for your own specific country. There are different ways that you can do that. If you come from a very big country, you can, like Australia, for example, you can find that very easily on the map. Just click on it and it gives you some key statistics. And then there's a link here for you to access your country profile. If you're from a smaller country or an island or somewhere that's not very easy to see on the map, you can click on this little search button here and type in the name of your country. So you can select the first letter. So let's go for Lao People's Democratic Republic as an example today, and it will zoom in on that country and allow you to click on it. So, and then if you click on the View Country Profile PDF, it will take you to your country's 2-page country profile. You might need to make that a bit bigger, mightn't there, so you can see it. And that's where you can see your country's data that was published as part of SAMI 2021. Just before I show you that, I just want to draw your attention to this little link here, which says View How to Read Country Profiles. And this will take you to a very comprehensive handbook guide, if you like, to how to read and use your country profile. So I haven't got time today to talk you through all of that detail. So if you want to know more, I would encourage you to visit this particular document. It's only available on the website in English, but there is, I'm aware of unofficial translations, definitely in French, and I think maybe in Spanish. So if that would be helpful to you, then I would encourage you to contact the leaders of this webinar series, and we can get that to you. But let's first look at the Lao country profile. It starts at the top with some just some general background contextual information about the sexual, reproductive, maternal, newborn health indicators for that country. But let's look at the specific workforce data. So this section here, full SRM&EH workforce availability, shows you what numbers your country submitted to the World Health Organization to tell them how many midwives you have, how many nurses you have, how many community health workers you have, how many general medical practitioners, how many obstetricians and gynecologists, and so on. And from what year that data comes from. So in most cases, it will be data from 2019. So it's already 4 years out of date, which is something I think we'll come back to a bit later for most countries. It gives you a head count. So how many have you got? And it also gives you in this blue column the number of graduates that are produced in the most recent year. So that helps us to start building up a picture of not only of today's workforce, but also potentially the workforce of the future. And are we actually producing enough midwives to meet the need in your country? Then at the bottom of the first page, we have some workforce modelling, some projections. So what we're doing here is comparing how many midwives you need in your country in order to meet all of the essential interventions, compared with how many that you have. And then you can see the approximate size of the shortage. And we then project those estimates forward to the year 2030. So if you continue to produce midwives and other health workers at the same rate that you are currently producing them, what's it going to look like in 2030? So that's done separately for midwives, nurses, doctors, and community health workers. Then on the second page, we have a little bit of information about the age and gender distribution of your midwives. And then a section here, which I think is particularly interesting for today's audience, which looks at the enabling environment. So what do we know about the policy environment in your country in terms of the existence of national policies, numbers of midwives in leadership positions? There's a few indicators here about education. So what types of education pathways exist in your country? What is their duration? How many of your midwife educators are themselves midwives? A bit of information about regulation in terms of policies, existence of regulatory bodies, the licensing processes, and then a little bit of information about professional associations. Then over here we have some more modelling results. So we have this indicator called the potential to meet the need. So if with the number of midwives and other workers that you currently have, how much of the need for essential care could your workforce meet? So in this particular case, looking at the 2021 figure, we can see that in Lao, even if everybody was working flat out all the time, they could only meet 62% of the need. And that's projected to improve by 2030 to almost 100%. So it looks as though Lao is heading basically in the right direction. Now, I'm going to stop sharing my screen now, but I just want to say just one more thing, if I may, Felicity, on this,
yes,
which is that we know that they're not all of these country profiles are correct and accurate and complete. There are gaps, there are inaccuracies. We've had people telling us this for the last 2 years, so we do know it's true. And I would say to you that now is the time to do something about that. If it's the case that your country profile is not correct or not complete, the time to act is now, so that when we repeat this activity, or if we repeat this activity in the future, we'll have better data, we'll have more useful data. So, and it takes time to advocate for improved data and improved data systems and improved data sharing with the UN, and among others. So please, I'm appealing to you not to wait for the next one, but to try and do something about it before the next one, if there is a problem in your country. I'll stop there, Felicity.
Oh, please don't. It could go on for ages. There's so much rich data in there that midwives and other maternity care providers can really unpick, and particularly the country profiles. I really urge everyone to look at those. And Andrea, I'm just mindful of time because we have another speaker, but we do have time at the end of this session. So please, people, put your comments in the box so that we can ask Andrea questions. But I'm going to ask you one question at the end, Andrea, around in terms of strengthening midwifery education, because we know this was one of the key recommendations that came out of this report, to invest in quality midwifery education. So what do you think is the key data for midwives to collect or to be aware of?
Relating specifically to education? Yes. I think there are a few essential data items that all countries should be able to access and use. First of all, what midwife education pathways exist in your country? Some countries only have one way to become a midwife. Some have 3, 4, 5 or 6 different ways to become a midwife. And there needs to be clarity about how many of these pathways exist and the extent to which each of them adheres to global standards for midwife education. So we know of many countries where there are some pathways that do adhere to these global standards, but there are others that don't adhere to those standards. And we don't know how many midwives are passing through each of those pathways, and therefore in the workforce, what are the competencies that midwives possess? What skills do they have? So that's, I think, for me, the number one important thing. Probably, actually, I say that equally as important is knowing how many midwives are being produced in your country each year. And that sounds like a really simple question that really shouldn't be too difficult to answer, but it's astonishing how difficult it is to answer. I think most countries, whether high income, middle income or low income, had difficulty answering this question for SAOME. And I think that's to do with the fact that there are these multiple pathways. And in many countries, the education of midwives takes place in both the public sector and the private sector. And there needs to be a mechanism to pull the data from all of those education institutions together in one place so that we can see what's happening in the country as a whole, or the state as a whole if it's a federal devolved structure. So I think the message for today is that, yes, of course, the people here are able to probably pull that information together for their own institution, but they need to then work together with their colleagues from other institutions across the rest of the country to pull that all together into a coherent data set that can allow us to see what's going on nationally. And then, if I may add one or two other, I think those are the two sort of really essential things, but it would also be nice to look at competencies. So what competencies do the graduates have? Are they all educated to the global standards? In reality as well as in theory. We can't improve the quality of midwife education without knowing where we are now and what the quality gaps are. So they need to be identified. And there's also a question about who is educating the midwives. Are they themselves midwives? And are there enough midwives available to educate the next generation? I think that's quite an important question. Okay, sorry, I've gone on too long, so I'll stop.
No, it's. I can see there's lots and lots of questions coming in and comments for you. I just want to finish that by saying, you know, it's such a challenge for faculties and for everyone out there. I know we've got global standards, and that's all very important, but sometimes it's impossible to meet those standards, to actually have midwifery educators who are educated to a standard, enabling them to provide quality education. So it really speaks to step 3, which is the next webinar around building public engagement and advocacy, so that we can use this data to push for change, to implement improvements in midwifery education. So lots to think about, a lot of data there to unpick. Thank you so much, Andrea. We're going to come back to you at the end of Brenda's session.
Sure.
So I know there's lots of comments. Erin, I'm going to hand you over now, so because I'm a very good timekeeper, and you're going to introduce our next speaker, I think.
Wonderful. Thank you, Felicity. And I just want to acknowledge the questions that we see in the chat. We're saving them, and we are going to answer as many as possible at the end. I see the questions for Andrea there, and we'll make sure you get those answers. All right. I am delighted that we will be speaking with Ms. Brenda Tembo Zulu this morning. And Brenda is a friend of mine, and she is also a senior midwife educator at Apex Medical University in Zambia, and has extensive experience in gathering data, in changing how things are going in her country of Zambia. She is currently undertaking a PhD examining rights-based approach to reducing maternal mortality. And this means that pretty soon we'll be calling you Dr. Zulu, right, Brenda? You got that coming up in the next year, I believe. Very excited about that. And you're also a champion of the Midwife Strengthening Framework, which is a collaboration of the Midwife Association in Zambia, ICM, as well as the national government. And you're working to create a national health plan that's got midwives as the lead maternity providers. And you've worked a little bit with ICM as well as Laerdal Global Medical on some new educational things. So you've been all over, and we've had a lot of opportunities to collaborate. But today we're going to be discussing data and evidence. So let's jump right into our first question. Thank you so much for joining us, Brenda.
Thank you so much, Erin.
Can you start with, you know, yesterday you and I were chatting, and I was saying, gosh, people are pretty intimidated by gathering data, and they feel like that's just for you, like you're an academic and you're getting your PhD. So can you tell me, like, let's start with why are people interested in this? Why should they be interested in this? Why should we be gathering data? And who should be gathering data?
Thank you so much for that question, Erin. Gathering of data is a very important thing to do, regardless of the sector in which one is. We normally do the collection of data in so many ways, even in our day-to-day activities, in home circles, and so on. And this is very important because it keeps somebody in the know. So when it comes to midwifery issues, gathering of data is very, very important in the sense that it brings about improvement in patient care. That is one of the most important things. So if you collect data, it will help you in the way you should manage the clients, what course of action you're going to take next, and so on and so forth. So coming to your question to say who should be collecting data, in midwifery circles, anybody, or in the health sector, anybody and everybody should collect data. And we all collect this data knowingly and unknowingly. Yeah, so for you to get to know, probably the example I can give is that for somebody to get to know, okay, we have this problem or we have this prevalence of a given condition, it is because of the data that has been collected. Probably in the registers, you're seeing these clients coming in and you're recording, oh, okay, this mother came in with antepartum hemorrhage, another one antepartum hemorrhage, another one antepartum hemorrhage. So the people that are recording, they could be different, but at the end of the day, when you look at this data, one will be able to interpret to say we should have a problem in in our community, in the sense that we have so many mothers coming in with this particular condition. And with that recording, probably you also make a follow-up in the way the care will be given to this mother and so on. So depending on the outcome of this, these cases that you'll be managing in an institution, you will be able to see whether the care that you are rendering, be it a midwife or an obstetrician or whatever, you will be able to evaluate the care depending on the outcome. So from that, you will be able to say, oh, okay, we made a mistake in this aspect and we need to improve. And this is where the improvement of patient care comes in. So the other importance of gathering data is to identify risk factors. Okay, so as we are collecting, we have so many data collecting tools in our facilities. And as you are collecting this information from the various clients, you will be able to identify risk factors as you are interacting with the clients. And once you identify these risk factors, you will be able to intervene in good time. The other reason why data is collected is just for quality assurance and audit. Very, very important. You need to know what you're dealing with. And quality is very important. Quality care is very important. All of us, well, regardless of our status or wherever whoever we are interacting with, we would want people to give us quality care or quality intervention. So equally, our mothers or our clients, they need this quality care from us. So with data collected, we are assured of offering this quality care to our clients, because we are going to know to say, oh, okay, this is what is needed. The last time we did this never worked out, so we need to change the course of direction. The other reason why data is collected, of course, is for research and evidence-based. And like you rightly put it earlier on to say, most people dread research like no man's business, and they leave it to people that are in the academia, which is not the case. In fact, for people in the academia to play around with this data, they rely on the people that are in the service area, because they're the ones that are interacting with the clients and they're the ones that collect this data. But unfortunately, in most settings, you find that in this clinical setting, the data may be incomplete and it becomes very difficult to use. And that's why probably it has been seen that it is very important for us as midwives to be engaged in data collection, so that we end up collecting data that is quality, data that we can use, so that at the end of the day, we can improve the care that we are offering to our clients. And the other reason I can think of is healthcare planning and resource allocation. So in whatever we do, we need to plan. Planning is very, very important, and you can only plan if you have some data with you. You need to know probably how many or what your population is that you are serving, and the common conditions and whatever it is. So with that kind of information, you will be able to plan on the service that you have to offer, the resources that you need to amass, so that you can cater for the population that you're dealing with. I think that was.
I'm going to interrupt you. Because I've got questions just based on that, which is great. I won't jump to the questions yet, but I want to. What I hear you saying is that data is power. If I have the information, I can use it as an advocacy tool for change. So I'm going to ask you specifically about education, and then we'll go to the tool that you've been working on. So I've heard you talk about advocacy and policy, but what about education? If you're gathering this information of practice data and risk factors and what's happening on the ground, how does that impact education?
Right. So the way information impacts education, very, very important also. It actually has some relations with what I was just talking about. But when you come to education, as you are training our midwives, you are training them, giving them this information so that they learn to use evidence-based practice. So with this information that they'll be interacting with, they will be able to definitely apply the evidence that will be gathered and applied in the different or various settings that are there. Believe you me, Erin, there are certain things that will work in your setting, the United States, and those things or interventions that are working in your setting may not work in my setting, Zambia. And so if you do a study, probably or you gather information in the US, and then you come and tell me, oh, okay, Brenda, when you're dealing with this condition, this is how you're supposed to do it. Then if I don't gather my information around in my setting, I'll pick on what you're telling me. And then when I apply here, it won't work. And tomorrow I'm going to say Erin is a liar because what she told me is not working in my setting. So what I need to do, I need also to, with what you have, probably I collect my own data here and see, apply what is workable in my setting. And so tomorrow when we are seated at that table and we are chatting, then you share your evidence and then I'll tell you, oh, fine, for me, that did not work and doesn't work. What works in my setting is this. So it is this evidence that I'm going to tell my students because they're in this setting, they're in Zambia. So I'll tell them to say, you hear about this, don't dispute, because this is what works out there. But in our setting, this is what is going to work. So interacting with students, these are students that are coming in and they want to learn more about midwifery and how we practice midwifery and everything else. So I should be able to give them this information and teach them how to gather data so that they can learn how to sort out problems that affect them in their locality using the evidence that they are gathering. And the other way in which data or information affects midwifery education is promotion of patient safety, promotion of patient safety and quality improvement. And this is our goal as midwives. We always strive to see that our patients are safe in our hands and the care that we're giving them is that of quality so that tomorrow they can come back. Even when they meet complications or whatever, they'll be able to rush to us. So because they know that they're going to find help there. But if the opposite is happening, our clients are not going to come and they're going to die in the cold out there. And this is not what we want. We want to reduce maternal mortalities in whichever way possible that we can as midwives. So teaching or incorporating data issues in midwifery education is very, very cardinal, very, very important, because at the end of the day, when our graduates are released to go and practice out there, they'll definitely understand the importance of collecting data, what type of data to be collected, and the accuracy, and so that, ultimately they give us the much needed data so that we can interpret and help in the practice at the end of the day.
I love the way you framed that. I feel like you made that so very clear. If we know what's happening as midwives, if we know what's happening in the practice settings and out in the real world, then we know what we need to teach our students. If there's an issue with nutrition, if our patients are struggling with nutrition, but we're not teaching that in the clinical setting, then that's going to be a broken system and we're going to see more problems. That's what I hear you saying. It's lovely. It's a lovely link. And I don't think that we often make the link as clearly as we should. So thank you for making that so clearly. We are super short on time, but I really want to ask you to tell us about the near miss audit tool that you have just helped create in Zambia, and talk a little bit, just a little bit about that before we move on to general questions, please.
All right, so thank you so much again, Erin, for that question. Yeah, as we were chatting, yes, I did make mention that I was a part of the team that was involved in the development of the near miss audit tool. So in our setting, what is trending is that what we have the maternal death audit review. So we have those tools where you review the maternal deaths and so on. But a gap was identified that we do not have a near miss audit tool. And the near miss audit tool is a tool that will be collecting data on clients that suffered maternal complications, severe complications, but they survived. They never died, they survived. So this tool will be able to collect the information about what happened, the care that was offered, and so on and so forth, so that people can learn from the interventions that were instituted, so that for subsequent management of the cases that will be, that they may come their way. So it is a very exciting tool. It was very, very educative, very interesting, really, to be a part of the developers of that tool. And I actually did share with you when we were discussing that I was an advocate in this meeting to say, please, let's have this also embedded in the midwifery curriculum, so that by the time our students are graduating, they have the know-how of how to interact with this tool. Believe you me, if our students get to know how to interact with these data collecting tools, we are not going to have any problems. Most of the problems that we are having now, they will be dealt with because people will get to know what is happening here and how to go about it, how to handle complications. And so, because they will have learned from others how they handled these issues. So that is pretty much about the near-miss audit tool. And after it has been piloted and everything else, their plans are that it should be adopted by the Ministry of Health, and it will be part of the tools that will be used on a daily basis or from time to time.
Great, thank you for that. It's amazing to hear how you and the other champions in Zambia are working to gather your own data, which is informing your process and allowing you to make better decisions. Like you said earlier, if I come in and tell you what to do based on my information and my research, it may not be as accurate as, it will never be as accurate as your own research and what's happening there. We're out of time, Brenda. I could talk to you all day. And you're getting so many comments. I'm sure you're not looking at the chat, but I'm seeing comments, so many saying, thank you, this is great. I think we're going to do panelist questions now. Is that correct, Felicity?
Wow, that was very stimulating, Erin and Brenda. I was busy looking at all the things coming in on the chat for both Andrea and Brenda. We've got two things to do, Erin. We forgot about the second poll questions. And before we do that, I think what would be really nice if faculty shared with everyone in the chat box the things that they have been doing in their practice that has worked well in terms of data collection. And also, Brenda, you make that great point about the curriculum and teaching students about data. And so what's worked? What are some of the tools that faculty are using? Would be lovely to share. And then we've got time for a couple of questions at the end. But Erin, did you want to continue with this poll?
Sure. Well, let's collect some more data, because that's actually what we're talking about, the power and the importance of data. So let's go ahead and collect some. So these questions, some of them actually come directly from the 7-step action plan, particularly the first one here. Do standards of midwifery care exist in your country? Are there close links between educational institutions and clinical settings? Do the educators in your faculty meet WHO standards for educator competencies? Again, it's going to be yes, no, or I don't know. Maybe you don't know the answer, or you don't know what educator competencies are. So go ahead and pop some answers in there. Do standards of midwifery care exist in your country? Are there close links between educational institutions and clinical settings? And do the educators in your faculty meet WHO standards for educator competencies? Verna, I trust you'll close that poll when you see a few answers come in. We're going to get to see in just a minute. Oh, go ahead.
Yeah, just a few more minutes.
Okay. I'm excited to see if there are links between the educational institution and the clinical settings, because that's just what Brenda was talking about, how important it is to know what's happening in the clinical setting to inform how we're educating our students. We talk a lot about that in education, the gap between what they're learning in the classroom and what they're seeing and doing in the clinical setting, and data could be a way to help close that gap. Let's see what we've got here. I feel like we should have some suspenseful music. Do standards of midwifery care exist in your country? Yes, 82%. Great, but always interesting to me, not sure, 7%. See how we can find that out. Are there close links between educational institutions and the clinical settings? 67% yes, 24% no. That's about 75-25. Do the educators in your faculty meet the WHO standards for educator competencies? There are 19 competencies. If you don't know about them, we should do an entire webinar on that as well. 55% say yes, and then the other 55% say either no or are unsure, don't know. So very interesting. It seems like there's some good links and there's some midwifery care standards. Now the question, if we could have a longer discussion, Felicity, would be, are the standards based on the data of the country? Are they based on what midwives need to be doing, right? Because the data could inform our scope of practice, letting us provide the care that the people that are needing in our country. Thank you so much for that. Shall we jump to questions and answers for our fantastic panelists? There are quite a few.
There are lots, and I think Rosa has been answering lots in the Q&A, which is great. So I've got a lot of questions around for you, Andrea, about guidance for collecting data. People are saying, well, how do we start collecting this data, and how do we correct the data that is clearly wrong, as you mentioned in the State of World Midwifery Report, and where do we send it to? Is there some sort of guidance around that?
Yes, I've put a few comments in the Q&A box, but just to summarise, I mean, how to collect the data is very much a difficult question. I think at the institutional level, it doesn't need to be anything very complicated. The difficulty, I think, comes when you try and collate it into one national database, and that's where the different education institutions and other stakeholders need to work collaboratively to develop a system that everyone can feed into, which I realise is an easy thing to say and not such an easy thing to achieve. But that is what needs to happen. And I think in a lot of countries, it doesn't yet happen. In terms of correcting the data, I think maybe I discussed this a little bit too much in my talk, in the sense that I think most of the data in SAOME is actually good, correct. It was all validated by the Ministry of Health in the respective country before it was published. If it wasn't possible to validate it, we didn't include it. However, despite that, I do know that there are issues with its accuracy. So if that is the case in your country, then there are two people that you need to speak to. One is the National Health Workforce Accounts focal point. Sorry to the translators, I don't know how you translate that. But there is somebody, or there should be somebody in every country, usually based within the Ministry of Health, who is responsible for collating the workforce numbers and giving them to the World Health Organization. So that is the person who you would need to speak to. If it's about health workforce numbers, if it's about the enabling environment, the education system and so on, then that information came from the Midwives Association within your country. So that you would need to talk to your Midwives Association to find out how they pulled that data together, and advise them if you think that was incorrect or inaccurate. Was there something else?
Thanks,
Did that cover everything?
No, that's a good point to remind us that everything was validated before that was published in the report, and we know it's not always possible to get totally accurate, but certainly the broad scope of the report is really very revealing. So I congratulate you for that.
Thank you.
Oh, look at that time. We've got only a few minutes to go. Brenda, a question for you. It was around, oh, now I've lost it. I've scrolled down. Erin, do you have one? Oh, here we go. Brenda, what strategies have you developed for the reduction of maternal mortality? Do you work on equity and education of inequalities?
All right, so thank you so much for that question. I'm sure the person that's posed that question understands the gravity and the extent of maternal mortalities in most settings. So Zambia being where it is, we lose a lot of mothers, and unfortunately the cause of deaths are preventable causes. Of course, there are certain causes that there's literally nothing much you can do about, but most of the causes are things that as midwives, we can do. And addressing maternal mortality, I can tell you, is something that has no one intervention to say, oh, okay, we're doing this and we are dealing with maternal mortalities, or we're addressing maternal mortalities. It is something that is multifaceted, and it calls for a whole lot of interventions. So I can just make mention of some of the interventions that Zambia is doing. Of course, data is one of them. When you collect this data, you will be able to tell or to know what is causing these maternal mortalities and or these deaths. And of course, that's why the near miss to is coming in, so that you get to know the kind of care that was given. And with the near miss to, it will be information will be gotten or transmitted almost immediately with the people that are attending to this woman, so that everybody else, country, world over, or the whole country or the whole system is able to see, to say, oh, okay, this is what is happening, or this is what happened. It's real-time data, and it will help people to act almost immediately. So there are so many interventions, like I indicated. Issues of respective maternity care come into play, issues of workforce. You want to have a midwife that is competent, that is knowledgeable, that is skillful. And then the issues of infrastructure, you have your equipment there. So it's a whole lot of thing that is near. Regulation also is a part of the issues that are being looked into in order to address these maternal deaths. So when you look at workforce, for instance, if an institution does not have the needed manpower, it means that even conditions or issues that can be dealt with cannot be resolved, because there's no one that is there to handle this mother. So this mother can just die by themselves. And when it comes to issues of respective maternity care, if in the facility we are not offering the respective care, our women, if we have the know-how, we have the skill, we have the knowledge and everything, we have the equipment, but the mother is not going to come to our facility because of fear of being abused or disrespected. So they would rather go or stay home and deliver in unsafe environments. So there are all these things, like I indicated. So it's a whole lot of issues put together if we are to win this battle.
Well answered, Brenda. That was a lot of indicators there, and lovely to bring in respectful maternity care, because that is the core of our work. Thank you. Thank you so much. And Erin, I know you wanted to address a question quickly, or to acknowledge something.
I just want to acknowledge that we saw a question come through the questions there that they're struggling. There are midwives that are also struggling. We are not all empowered, we're not all creating tools, and we're not all writing summary reports. Some of us are working in places where there is bias and we are treated differently or badly because we're midwives. And we can't address that in full today. We will talk about it a lot more in advocacy, so I hope you'll come back for that one. And know that just in terms of data, using the data and showing that midwives are a fantastic way to provide care does start to help elevate our status. It has certainly worked here in the United States, where we have been targeted for many years as second-class providers. So please, whoever posted that anonymous question, come back to advocacy so we can discuss it more. And there's so many questions we didn't answer, but in our follow-up email, lots more answers to come, maybe even a second backup small recording where we can ask some questions of our fantastic panelists. Felicity, back to you to wrap up today's session.
Okay, thank you. Thanks, Bruna. I'm not even going to get to this slide, because what I really want to say is to thank all of you for coming today and showing your support for midwifery education, and a really special thank you to Brenda Zulu and to our lovely Andrea Nova, who who has given us so much information for this session. And I've just had a message from our colleague Sarah Baziv suggesting that we provide a template around the 7 steps for faculty to work with. So we'll get onto that and provide that at the next webinar. So thank you for that. Thanks, Bruna.
And thank you to our fantastic interpreters that come and keep up with us, because they are not midwives, and they do a wonderful job making sure that lots of folks can have the information all over the world.
Yeah, and thanks, Rosa. And the resources are in the chat, I think. Is that right, for the slides? Great. Thanks, Bruna. And we'll just slip to the last slide and wish everyone well and hope to see you for the next webinar in 2 weeks' time, which is Build Public Engagement and Advocacy, which is very much dovetails into this. So go well, everyone, and take care. Thank you.
Thank you. Bye.
Thanks,
Bye.
Andrea.
Thank you all. Thank you, Brenda. Thanks, Andrea.
Thank you.
Thank you, Bruna. Thank you, Kennedy, for coming. Thank you, Priscilla, Christina, everybody in the audience.
Dance our way out. Thanks, everyone. Take care.